Hello everyone, I am Dr. Lakhan, a neurologist. In this video, we will learn about median nerve and its clinical correlation. I will teach how we as a clinician localize median nerve lesions. And we will discuss important signs like pointing index sign, Ape Thumb Deformity, OK sign, and clinical tests like Phalen signs. So before watching this video, I would recommend you to watch our previous videos on muscles of hands and forearms and also radial and ulnar nerve. So let us start the video. First of all, anatomy and course. The median nerve is formed by contributions from both lateral and medial cord of brachial plexus, carrying fibers from C5 to T1 nerve roots. Now let us see the course. After arising, it descends in the arm. Importantly, like ulnar nerve, median nerve also do not have any supply, either motor or sensory, in the arm. Then it enters the forearm and passes between two heads of pronator teres. It then runs in forearm between FDP and FDS. In the forearm, it supplies most of the flexor muscles, including pronator teres, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis. Then it gives branch which is called as anterior introtious nerve. It supplies flexor pollicis longus, lateral half of flexor digitorum profundus, and pronator quadratus. Then the median nerve continues distally and gives a palmar cutaneous branch, which arises before the flexor retinaculum and enters the hand or palm, passing above the flexor retinaculum. Hence, it is not a part of carpal tunnel. It supplies lateral part of skin of the palm. And this concept is important to understand carpal tunnel syndrome. After that, median nerve passes through carpal tunnel beneath the flexor retinaculum and enters the hand. In the hand, it gives recurrent motor branch to supply thenar muscles, first and second lumbricals. Also, it supplies superficial head of flexor pollicis brevis. Remember, deep head is supplied by ulnar nerve. And lastly, digital sensory branches to supply lateral or radial 3.5 fingers, including nail beds, that is thumb, index, middle, and half ring finger. Now this is image from my previous video on forearm muscles. You can see clearly median nerve is between FDS and FDP and supplies superficial and intermediate forearm muscles, and anterior introtious nerve supplies deep muscles. It is easy to remember muscles supplied by median nerve in the hand by mnemonic called as loaf muscles, which includes lateral lumbricals, opponens pollicis, abductor pollicis brevis, and superficial head of flexor pollicis brevis. So this was all about anatomy of median nerve. And this is summary of median nerve anatomy, which is important for further understanding of localization. You can take screenshot if you want. Now we will study clinical lesions of median nerve. For clinical localization, we study lesions at above elbow, at elbow, that is called as pronator syndrome, pure AIN lesion, then at wrist, which is called as carpal tunnel syndrome, or lesion in palm, that is a recurrent branch injury. First is median nerve lesion above elbow, and common causes are supracondylar fracture and trauma. Here, since the lesion is proximal, both forearm and hand muscles are affected, and the findings are loss of pronation, weak wrist flexion with ulnar deviation, loss of flexion of index and middle finger. So when patient try to flex the fist, only ring and little finger flexes, and this is called as hand of benediction. Another sign is pointing index finger. As FDP of lateral half is affected, middle finger along with the ring and little finger can be partially or completely flexed. The only finger which is not flexed is index finger, hence it is known as pointing index sign. Also there is sensory loss at all median innervated areas, as it is proximal lesion, which is lateral palm and lateral 3.5 digits including nail beds. Now lesion at elbow, which is also called as pronator syndrome. Features are similar to that of above elbow lesion, but degree of pronation depends on severity of pronator teres involvement. It is caused by compression of nerve at pronator teres, or compression by lacertus fibrosis or bicipital aponeurosis. It is just a fibrous band, or compression at FDS arch. The clinical features are forearm pain, weak pronation, and weak finger flexion, and sensory features are similar to that of elbow lesions. Next is pure anterior interosseous nerve lesion. This is pure motor nerve, and the affected muscles are flexor pollicis longus, lateral half of FDP, and pronator quadratus. This is tested with something called as OK sign. When you ask patient to make OK sign with thumb and index finger, what normally happens is flexor pollicis longus flexes thumb at distal interphalangeal joint or interphalangeal joint, and FDP lateral half flexes index finger distal interphalangeal joint. So you can make tip to tip circle with index finger and thumb. But in AIN palsy, FPL and FDP both are paralyzed. So the thumb and index finger cannot flex the distal joints. As a result, there is no tip to tip contact. Instead, pads or pulp touches each other, making triangle appearance instead of circle. Hence, it is called as unable to make OK sign. Next and important is carpal tunnel syndrome, which we see commonly in clinical practice. It is caused by multiple reasons like diabetes, hypothyroid, or during pregnancy, or because of autoimmune conditions like rheumatoid arthritis. Here, thenar muscles are affected, causing thenar wasting. Also, there is loss of thumb opposition, causing something called as Ape Thumb Deformity. Let me explain this. Thumb opposition movement is mainly by opponent's pollicis. In median nerve palsy, this opponent's pollicis is paralyzed. So, thumb cannot oppose and cannot move across the palm. But adductor pollicis, which adducts the thumb, remains intact because it is supplied by ulnar nerve. This forces thumb in medially adducted position, and this is called as ape thumb deformity. Apart from these motor findings, there will be tingling paresthesias on sensory loss over lateral 3.5 digits. The important localization point is palm sensation is paired because, as we studied in anatomy section, palmar cutaneous branch passes above the carpal tunnel. Hence, it is paired. Remember friends, you won't see all findings in these patients clinically. It completely depends on extent of compression. And last is lesion at palm or recurrent branch lesion. It is caused by trauma or surgical injury. Here there will be weakness of only thenar muscles and loss of thumb opposition. Sensations are spared. Now let us summarize this localization in tabular format. So we learned lesion above elbow, at elbow, pure AIN lesion, carpal tunnel syndrome, and lesion at palm. Now if you see our anatomy diagram, thenar muscles and thumb apposition will be affected in all types except pure anterior interosseous nerve injury, as it does not supply thenar muscles. Rest all proximal and distal lesions will affect thenar muscles. Then pronation will be only weak when pronator teres is affected, which is possible in proximal lesions, which are at and above elbow. It will be intact in other lesions. Then index and middle finger flexion and also OK sign are done by forearm muscles. Hence, distal lesions like carpal tunnel and palm won't involve them. It will be affected in proximal lesions only. Important sensory localization point is palmar sensation are affected in proximal lesions and preserved in distal lesions at carpal tunnel and lesions at palm, as it is given proximally and passes above flexor retinaculum. And obviously, sensations are not affected in AIN nerve lesion as it is pure motor nerve. And lastly, sensation over lateral 3.5 fingers are affected in all lesions except AIN lesion and recurrent branch lesion. So this was localization summary for median nerve. Now let us discuss important name signs or tests for median nerve. First is Phalen's test. Flex both wrists maximally and keep dorsum of hands pressed together for 30 to 60 seconds. If there is reproduction of tingling or numbness or pain in lateral 3.5 fingers, test is called as positive. And reverse Phalen's is wrist extension instead of wrist flexion. Second is Tinel sign. Tap or percuss over median nerve at the wrist, just proximal to or at the flexor retinaculum. The tingling or shock-like sensation radiating to lateral chain of fingers means a positive test. It is seen in carpal tunnel syndrome and also during nerve regeneration or recovery. So proximal progression of tingling or tinel sign is good sign of recovery. Then I already discussed about hand of benediction, where on making a fist, index and middle fingers fail to flex, while ring and little fingers flex normally. It is seen in high median nerve lesion due to loss of FDS and lateral FDP. Next is pointing index sign, when middle finger can be flexed completely or partially, and only finger which is not flexed is index finger. So it is called as pointing index sign. Then ape thumb deformity. As discussed, thumb lies in adducted and in plane of palm due to loss of opposition of opponent's pollicis, and adductor pollicis, which is ulnar innervated muscle, is dominated. And last is OK sign deformity. Patient is unable to make proper OK sign, that is tip to tip pinch, and instead forms a pulp to pulp pinch, making a triangular appearance. It is seen in anterior interosseous nerve injury due to paralysis of FPL and index finger FDP, where flexion of distal joints of thumb and index fingers are affected. So this was complete discussion of median nerve anatomy, clinical localization and important named signs. If you understand this properly, you will never confuse median nerve lesions in exam or clinical practice. And do like, share and subscribe the channel. Thank you.